If you would like to say who you are and your responsibilities, that would be helpful. And that will now be on the record.
So I'm Nigel Acheson. I'm one of the Deputy Chief Inspectors at the Care Quality Commission. My responsibilities are around hospitals, and the declarations that I have are twofold. One represents a payment that I had by Baxter Pharmaceuticals for giving a lecture which wasn't related to their products, but I thought I'd mention that. And the other was some training that I underwent, which was in advanced laparoscopic surgery, and that course in Belfast was completely funded by Johnson & Johnson.
Right, thank you very much.
And I'm Nigel Sparrow. I'm the Senior National GP Advisor at the Care Quality Commission, former GP, and held various roles at the Royal College of GPs in education.
Right, thank you very much. So if I perhaps could start by saying, as I understand it, and please put me right if I haven't got this right, but you're sponsored by the Department of Health and Social Care, and I'm not quite sure how that sort of in any way influences you, because I think the CQC is independent and prizes its independence. But you're also accountable to Parliament through the Health and Social Care Committee. And I'm just wondering how that fits together, and does one take precedence over the other, or is it, well, you tell me how it works.
So we are an independent regulator. We act on the side of people, and our focus is on people that use services, and that's where our priorities lie. Although we are funded through government funds, we are largely now fee-based in terms of our funding, but we are completely independent of government.
Right, okay, thank you. Anything you want to add?
Yeah, no, that's absolutely right.
That's fine. All right, well, thank you. So you've got this dual accountability in some respects, but also you're presumably having to interact a lot with other arm's length bodies. And I'm thinking particularly of the MHRA and NHS Improvement. And I wonder how that works, if you could tell us.
Certainly with NHS Improvement, we have regular meetings with NHS Improvement now being formalised into meetings where we share intelligence. There's a formal group now which is much wider than just ourselves, which has got a number of stakeholders on it, which again is to share early concerns, and that's a relatively recent development. In terms of MRHA, NICE, we do meet from time to time with them, but it wouldn't be in the same operational way that we meet with the other members of that Responding to Concerns group.
So we've been on a CQC inspection, so we've sort of had a taste of only one, so, and I appreciate you can't draw conclusions from one visit, but it was very interesting. But what I really wondered was that you do say on your website, I think, that you're very involved with patients, you want to hear from patients. And how do you do that? Because I think some of us feel it's very much a sort of an organisational body, and I'm just wondering how you get the feedback, because the inspection is very much looking at the organisation and whether it's well led and all the rest of it. But how do you get the impact from individual users of the service?
So in a number of different ways. So we run the number of the national patient surveys and we share the result of those surveys, which can be broken down to individual provider level. This is for the hospital side rather than primary care. And encourage the hospitals as a result of that. For example, the recent maternity patient survey encouraged the individual trust not just to look at their own information, but then to use that as the basis for reaching out to their local patient groups to involve those. So we're encouraging that to happen. In addition, we have a huge number of contacts that members of the public make to our National Contact Centre, which is based up in Newcastle, hundreds of thousands each year. And from those, if there are concerns about a particular provider, then that information is shared with one of our colleagues who is the responsible connecting colleague with the organisation concerned, and they will pick those up either individually or as part of the information that we use to help us decide what our regulatory interaction with providers may be.
Right. Can I ask on then surveys, because of course we've been taking a great interest in the maternity services. survey that you've been running. How do you choose your questions?
So the questions are put together by a panel. So there's a panel. The panel has patients, experts by experience on the panels. So following the survey this year that's just been published, there was a meeting to review those questions, which included two women who have recently experienced a maternity journey, and they were able to help us consider those questions. There is a process around how the questions are then moved on from year to year in order to make sure that the questions remain comparable, the surveys remain comparable. But certainly we test with those experts by experience the form of questions, what they feel are the important topics, if there's anything that's missing from the survey topics that they feel should be added. So we put a great store by the experience and expertise those colleagues give us.
So if you have people, organisations, individuals who feel that the questions aren't quite the right questions, or maybe one or two questions, you're happy to take that into consideration with the next survey? Yes,
so for the next survey, I'm not sure whether the questions have been finalised as a result of the process that so I took part in one of those meetings 2 or 3 months ago, so I'm not sure at what stage next year's questions are finalised. But certainly, yes, we welcome feedback, obviously, on the survey.
Watch this space, that's all I'm saying. Right, over to you, Cyril.
I think maybe the processes have changed since I was an observer on a hospital inspection. But I do remember the briefing that took place before the team went to the hospitals. It included a session from your data analyst about what they knew about the hospital. And they talked about the mortality rates of the hospital. To what extent do you take other outcomes into account when you visit, in particular specific clinical outcomes or patient-related outcome measure or patient experience? Do you get that information, and then are you briefed now to go and inquire about those much more detailed questions?
So we get the breakdown of both the patient survey pertinent to the provider and also the staff survey pertinent to the provider. So those are two of the formal bits of information that we have. We also are involved with the HQIP clinical audit process and programs, and as you know, there are a very large number of those. And in fact, what we run at CQC is the outlier process for those. So where providers were given audit or an outlier, we then it's the CQC that makes contact with the provider to inquire about what that might mean, what steps the organisation is taking to both look at and then improve upon the service that has been audited. And so that information also feeds into the data pack of intelligence that we have available to inspectors, as does things like complaints and the way that and the timeliness of how complaints have been handled within a provider. And as I said, the information, if members of the public have contacted our contact centre nationally, in addition to that, then we would get that sort of what one might call potentially softer or intelligence from another route. We also get that.
And the record on serious incidents and
yes.
inquiries, that would be part of that?
Absolutely, yes, it would, yes. And again, the timeliness of how those have been dealt with, and on our well-led inspection, which is a new part of the hospital inspection process, we will assess how those incidents have been handled.
Because the CQC, as a regulator, it seems to me is a very important component of ensuring safety in our hospitals. We are in the situation where we've met hundreds of women whose lives have been very severely damaged by something that went wrong. I'm particularly talking about the use of surgical methods, stretching of incontinence or pelvic organ prolapse. And it's taken the women forming groups and working with politicians to draw it to the attention of our profession or our National Health Service. And that doesn't seem right to me. With your experience, and of course there are many players, and we're meeting them all, we've seen the MHRA and the General Medical Council, can you think of something that we ought to be thinking of to try and make sure this never happens again?
So one of the things that we're very interested in the work that we're doing is looking at processes that are in place. And for example, if we were talking about a new either treatment or a new piece of technology, for example, one of the things that we would be looking at, and we do look at now, is in an organisation, what is the process whereby the organisation itself make sure that those are being implemented in a safe manner. It would be difficult for us because we inspect, for 2 or 3 days at, intervals. It would be difficult for us to be in all of that detail. So what we do is we're developing ways of checking the processes that are in place. I think one of the other things that we are really keen to explore is to see how we could use other sources of information. For example, the GIRF programme. And the information
Getting It Right First Time
program, and the information that they have as a way that we could assess the standard, because that's what they're doing. They're giving that information and sharing it back to the departments to tell them something about the quality of the care that's being provided. And so we're looking for ways that we could use that sort of information as one of the lenses through which we would look at a provider.
Do you look at the audit reports that go to trust boards?
Again, it's we sample them rather than see every single one of them.
So if we were inspecting a hospital, you would see the audit report of that hospital?
That would be part of the information that we would have available to us before we did the well-led part of the inspection as part of our assessment of governance in the organisation.
And to what extent would you engage with the revalidation process run by the General Medical Council?
So we're at the beginning of that process. One of the reasons that I was so keen to move, having formerly been one of the higher level responsible officers, was to try and see how we can explore using those two forms of regulation in a more intertwined way. And I mentioned a little while ago the National Audit Programme. It seems to me that would be an area we look at from a CQC point of view. It was an area that I was beginning with colleagues to look at from an RO regulations point of view, to ask colleagues to have had a formal performance review of their practice. And because national audits are generally accepted by the profession, the colleagues should be submitting cases to them. And we hope that would be something that could be built into the annual performance review for a colleague, reflected upon in their appraisal. And that's something that we could then triangulate during a CQC, either visit or monitoring phase, because the intelligence that you mentioned at the beginning that we used to use just in our comprehensive inspection programme, we now have a plan to use that intelligence, that data, as a much more ongoing part of how we regulate providers.
So when we're talking about connectivity between the different regulators, and of course we know there are a lot of regulators, and sometimes that is the problem if you're trying to run a hospital. But to what extent do you connect with, say, the National Patient Safety part of NHS improvement?
I don't know, Nigel, if you want to comment. I mean, at the moment with NHS E&I in a position where they're just reforming and coming together. Although we've had at the moment relatively informal discussions with Aidan Fowler, who's the lead for patient safety, we are planning, once their structure gets more established, to formalise some of that. And as I say, in the emerging concerns group that's been set up, in some of the formal meetings that we have with NHS Improvement currently, hopefully we can build some of those quality areas into those discussions too. But it's early days.
So there's a lot of conversation that clearly taking place now between the different partners in trying to ensure or improve patient safety. And you've been involved before in your previous life with the role of the General Medical Council.
Yeah.
It would be very helpful, I think, to us, and certainly to me, if you could actually pop down on paper what are the changes that are taking place at the moment, and the background to them, and what you foresee as being a better outcome, because we've got to do everything, all of us, to make sure this doesn't happen again, and that would be very useful. Finally, for me, no time being, private sector. To what extent does what you've said now in relation to National Health Service hospitals, apply to your inspections of private hospitals?
So the basic inspection process is the same. One of the reasons why we're so keen to push the idea of the, for example, audits or GIRFT or that sort of data collection and sharing as a standard is that we think that could then apply in the independent health sector, where it's more difficult for us currently to get that sort of data and information. What I would say though is in terms of private practice, that NHS funded private practice, about 85% of that is provided by 5 providers. They, through primarily the RO regulations, I think, have begun to meet on a very regular basis and are very alert to the fact that they need to get on the front foot in terms of assuring the quality of the services that are provided. And again, with the mesh issue, when the letter went out to all providers, including private providers, those certainly those big 5 were very, very keen to get involved in a discussion about how they would put in place a stop to the
Do you find the relationship is different between the people providing the care, particularly the doctors, and the institution? Because within the NHS, the institution, as the employer, has major responsibility.
So again, I think that's changed very. I mean, I haven't spoken to many colleagues who are providing private practice in those settings, but talking to the responsible officers in those settings and 1 or 2 of the chief executives of those organisations, they definitely have taken a very different view in a very short
Nigel,
time.
just for the record, would you just explain what the responsible officer is?
Sorry, yes. So every doctor who is practicing in this country, be they a GP, hospital doctor, or in any sphere, has to be revalidated by the General Medical Council every 5 years. And in order to help the GMC make that decision and recommendation to allow a doctor to continue to hold a licence to practice, they have to undertake a process of annual appraisal. And that annual appraisal then goes through to a responsible officer, which every doctor is connected to, bar a small number whose connection is directly to the General Medical Council. And the responsible officer then every 5 years, on the basis of the outputs of those annual appraisals, will make a recommendation to the GMC that this is a doctor who the responsible officer feels should be recommended for a revalidation recommendation, or that there isn't enough information, in which case that decision can be deferred, and in thankfully now relatively unusual circumstances, there will be a small number of doctors who don't engage with that process in a way that the responsible officer can make a recommendation of either a positive recommendation, a deferral, and in fact we've recommended to the General Medical Council that this doctor is not engaging in the process, whereby the General Medical Council then get involved with a process which can lead to a doctor losing their licence.
Thank you very much.
Can I just ask you, originally I think the CQC was employed to inspect hospitals. Can I ask a bit about primary care, about GP inspections, because I think that's been running not for so long, and I just wonder how that works, because we've had quite a lot of concern expressed from patients about the GPs understanding their issues and the question of referrals.
So we started inspecting general practices in 2014 and completed our first comprehensive round of inspections last year, and 2017. This is the first time that general practice was ever inspected, and we inspected them against the CQC's 5 key questions, whether they're safe, caring, effective, responsive, or well led, and we rated each general practice. At the end of that process, on the first inspections, about 4% of practices were rated as inadequate and about 13% requiring improvement, and the rest were good or outstanding. Because we re-inspect practices then that are inadequate or requiring improvement quite quickly, so if you're inadequate, the inspection is 6 months later, and requiring improvement 1 year later. So by the end of the first round of inspections, 95% of practices were good or outstanding, and only 1% were inadequate, and about 3 or 4% I think were requiring improvement. So there was an improvement journey from where we found in our first round of inspections. because general practice had never been inspected before, it was a learning exercise for all of us, and certainly safe was one of the key questions that was more commonly rated as inadequate or requiring improvement. And in particular with this, with the inquiry we're talking about now, in terms of drugs such as sodium valproate, we always ask, for example, how practices react to safety alerts. And we look for examples. And we refined our processes much more from when we started, and we certainly now examine more records to check that those alerts have been acted upon. And in terms of valproate, because this is the most important safety alert that's happened in general practice for a very long time, our inspectors always ask about valproate on every inspection now. And our specialist advisor, who is on those at an inspection, will look at records of patients who shouldn't be taking valproate, basically. And all our GP inspections have a GP, a practicing GP, on the inspection team, as well as an inspector. So we have professional input at every general practice inspection.
We were told by one of the patient groups, who is very active, very well informed, and they had run a survey, and they were finding that women were still being prescribed sodium valproate when they were epileptics and in the early stages of pregnancy. So I'm just wondering if is your inspection regime comprehensive enough? Because presumably you're only taking a certain percentage of GPs because there are so many in the service.
So now we've finished our first round of inspections, our process of inspection has changed, and we're doing much more focused and targeted inspections based on intelligence. And so for practices that have been rated as inadequate or requiring improvement, they will get the same process of a comprehensive inspection in those same time intervals. But for practices that have been rated good or outstanding, will now be subject to what's called an annual regulatory review, whereby an inspector with some clinical input will review the data from each general practice, combine that with information which we've received from patients, from NHS England and CCGs, and put that together. And we ask the practice as well for their input. And put it all together and decide at the end of that annual regulatory review whether a practice will be inspected in that year or not. If it's not inspected, it will get another annual regulatory review the following year, but all practices that have been rated either good or outstanding will have an inspection within 5 years. That may not be a comprehensive inspection, it's more likely to be a focused inspection where we look at well-led and effective, but using trigger questions from well-led to get into safe, so that we make sure as much as we can that practices are safe. But as you said, we can't possibly inspect every general practice all the time, and it is a snapshot when we go in at that particular moment in time. So we can be assured when we do the inspection now that for example, valproate is being managed appropriately, but we do still see practices 10 years on after the first alert that people are still being prescribed valproate in childbearing years. And we found an example only a couple of weeks ago, which was completely shocking, that at this stage, after all this, we're still finding cases, which makes the case for why we're doing this now and why we've focused particularly on valproate. And we've only done that in the last 6 months. So I can give you assurance for the last 6 months. I can't give you any assurance over the previous year or two that valproate would have been looked at, for example, on every inspection. But we will have asked that our safety alerts being managed appropriately. If we find evidence that they're not, they would then be in breach of a regulation. I think it's regulation 12 for safe care and treatment. If my memory serves me correctly.
And you would take action then?
Yes, that would be a breach of regulation, and would be followed up and managed accordingly.
Thank you very much.
So what just on that question of the action you take, if you take the example that you just talked about of a practice that is still prescribing valproate to women of childbearing age, what action can you take to quickly ensure that women are protected from exposure?
So they would be in breach of Regulation 12, and therefore they would get probably a warning notice and would be followed up immediately, and the inspector would be liaising with that practice straight away. We would also inform other regulators. So, for example, if it was an individual GP, we would inform the GMC, and certainly through the responsible officer of what we find, because we do need to share, such serious information. But we will follow that up. What I can't say is that we can never say that we can give a 100% guarantee, because we can't do that with the snapshot inspection programs that we do.
Okay. Can I just ask you something about the fundamental standards of care that I think you set out on your website about as to what patients should be able to expect? So they include things like, and this applies in primary care and in secondary care, being treated with dignity and respect, providing informed consent to treatment, not being put at risk of avoidable harm, and receiving a candid explanation when things go wrong. As Baroness Cumbridge said, we've been up and down the entire country, and we've met many hundreds of people across the three areas that we're looking at, not just in relation to MESH. And I think it's safe to say in all of those areas, the overwhelming majority, if not all of the people we've met, have said that some or all of those standards have failed to have been met. And we're talking about many hundreds of people, in addition to the thousands who've contacted us separately by email and by phone. Does that surprise you?
I think when, as Nigel said, when we actually physically are in an environment, we have got a set of supporting questions which we ask, and evidence that we look for each of those elements, upon which we then make a judgment in each of those domains that you mentioned, and we will say either what we find appears to be outstanding, good, requires improvement, or inadequate. We also, as part of the short time we've got to inspect, as we heard, we've got some information that we gather which helps us both plan the parts of certainly a provider that we will inspect, because we currently don't. If we went to a trust, for example, we wouldn't inspect every single department in that trust. Currently, we would select on the information we have. But we would also use some of the tests I mentioned earlier on of process, and what we're beginning to learn from the addition to our inspection process of providers that we've added is this well-led inspection which tests the board, it tests the effectiveness of the governance structures, the audit in the organisation, and what we're beginning to find is that part of our inspection is a pretty good measure and seems to correspond with how good or outstanding we find some of the other services. But given that we can't be in every bit of every hospital, what we are really encouraging through the work that we're doing is that sense of organisations becoming improving organisations really embracing and we look for this evidence that they have a quality improvement strategy, that they've got a patient focus, and in some of the outstanding organisations, you can see that and hear that from all the members of staff that we chat to. We talk to a lot of staff when we're on site. We talk to as many patients and relatives as we can when we're on site, and we report what they tell us. Sometimes what they tell us is that things are very good and the staff are very caring, and you'll see some of that in our reports. Equally, sometimes we'll hear some of the comments that you've made. So am I surprised that the comments are being made? Unfortunately not. But we think that our approach is one that is not only looking for evidence of good practice, and we hold a mirror up if we don't think that it's good, but also that our message to organisations and providers as we go there is really to encourage and share with them what good looks like.
And in primary care and GP practices, how do you factor in, when you do an inspection of a particular GP practice, how do you factor in the experience of patients who are on their list?
So when we're on the inspection, prior to the inspection, we give out comment cards. So comment cards are filled in by patients. We talk to the patient partnership group, members of the patient partnership group. We talk to people on the inspection. We do get a lot of information from patients prior to an inspection. That often prompts the inspection. So through our contact centre, we get lots and lots of information. And, certainly the practices that, the worst practices, almost always there has been information received from patients which has contributed to that inspection. But we do talk to people on the day. We do look at the patient survey. We look at NHS choices. We look at anywhere where we can get information that the public might be able to tell us about that practice. In terms of consent, we always look for examples of consent. We check the understanding of the doctors and the nurses. Do they understand consent? We look at complaints. We make sure that there is a complaints process which has the right standards and people are followed up according to that. So we try as hard as we can to get that information. Caring is one of the most difficult of the key questions to rate. When we do find poor caring, it is almost the exception, because even the practices that are the most unsafe, ineffective and poorly led, they will often get good reviews from patients, unfortunately, because patients only rate what they've experienced. They've never experienced anything better. Unfortunately, they'll say that's okay, and that isn't okay. And so we need to raise people's expectations of the care that they're entitled to receive.
The other thing I wanted to ask about was the regulatory system as a whole. You regulate entities, to put it straightforwardly, I suppose. Others regulate individuals, and others still regulate system-wide. Is there a risk in that kind of approach to regulation of gaps appearing and issues not being detected? And is that a greater issue than overlap and duplication?
There is a risk, certainly. And because we have good communication between the GMC, NMC and ourselves, we try and close as many of those gaps as we can. But we regulate regulated providers, but those regulated providers contain individuals who are regulated by individual regulators. And we have found examples where doctors have got through the revalidation process but are delivering really poor care. And therefore we have that conversation straight away then with the responsible officer and with the GMC. And similarly, the GMC will highlight to us areas of poor practice, which then would trigger an inspection of the provider themselves.
So the solution to the problem of underlapping as opposed to overlapping within the regulatory system is what? To make sure you all speak to each other more often? Communication
and sharing of information is really important. The GMC are a little bit stuck because of Section 35 of the Medical Act to disclose information until a case has been proven, but the responsible officer can share information of concerns, and that's the most valuable conversation that we have because of the restrictions the GMC have until a case has been proven.
The other thing I was going to ask about, if I may, was the report you did called Beyond Barriers, which was specifically about elderly people and their interaction with health and social care systems. And that was quite a concerning report. I think the conclusions were alarming reading. Organisations prioritise their own ends rather than service users' outcomes, or even system responsibilities, for example. But we also noticed that nothing's actually happened, as far as we can tell, in relation to that report, and you didn't get a response from the Department of Health and Social Care. Is that correct?
So there has been one relatively recently, and the Secretary of State has communicated with our Chief Executive, I think I'm right in saying, James, and we are in discussions about doing some more of that work in the future, although the shape of that hasn't been absolutely finalised. One of the other outputs of that work, and you are right that as we are currently constituted, we regulate providers rather than systems, and have to be invited by the Secretary of State in order to do that work. But as I say, there is that it looks like, fortunately, we'll be able to carry on that work. But in response to the initial report, we are linking up with the first wave of these ICSs, these new organisational forms. And in fact, one of us, I'm the DCI who links to one of those ICSs. I was there with the
integrated care
system. Sorry, I was there with the leaders in West Berkshire yesterday, trying to explore with them, are there things that they think that we as the regulators are doing that are hindering some of the work they're trying to do to work across their boundaries, and other things that we could do to help. So we're beginning those discussions alongside that work to try and explore how the regulatory system could help improve the transfer across those organisational boundaries. I think one of the things that we do in a well-led inspection of a provider, accepting the boundary of our current legislatory framework, is that we want to understand how a provider is playing its part in its wider system. And on almost every occasion I can think of, the providers, when we do that well-led inspection, are very keen to tell us about some of the work that they're doing as part of, and often a very important part of, their local system. And so, that is a direction of travel, and I think our report was a point in time which said, actually, do you know what, there are real risks for members of the public as individuals across the...
Not just elderly people.
Well, indeed, although that report was...
but the concerns go wider.
They do,
right.
No, they absolutely do.
Can I ask one final question from me for the moment? When you think about patient safety, is there a difference in risk to patient safety as between private providers and NHS providers, in your experience and opinion?
I think that in general practice, the big risk is certainly the online private providers, and that's an area which we've tried to focus on a lot in the last year, because of the lack of sharing of information sometimes, because of the ease of access to medications, and because the GP may not know about that. And we only regulate, where we look at online providers, we only regulate providers that are based in England employing GMC doctors. We know that a large amount of online stuff is performed by providers based overseas, providers that may be based in England but using doctors based overseas, and we have no control over that through our current regulatory framework. And that is a major risk, and particularly with drugs such as valproate, there is conceivably examples that patients may be able to obtain the drugs of their choice, not understanding the risks that they're undertaking.
And in secondary care?
So in secondary care, we are just at the beginning of the process to try and inspect all of the... There are a large number of independent health providers of various sorts, and we're at the beginning of that inspection process. So it'd be too early to say about and those are often quite small. As I mentioned earlier on, some of the really bigger providers, we've had a very useful dialogue over the last certainly 6 months that I've been in CQC, and probably the 6 months before that in my previous role, where those providers are really beginning to understand, and we're beginning to be able to make better use of the fact that the individual doctors who work in those providers have to, as part of their annual appraisal, include information about their whole scope of practice, wherever that practice occurs. And as Nigel said, some of that information sharing, we now have much better ways of insisting that information sharing takes place two-way, and I think we'll begin to see over the next, it's already starting, but I think it can only increase the safety of the care that's provided, because those doctors will not be able to, for example, practice in a private setting in one way or one set of procedures, and not be able to demonstrate to their responsible officer that they're appropriately trained and keeping up to date in order to do that. So that, I think, is palpably changing.
And when you look at the system overall, as we just discussed it, that's private sector, public sector, the system regulators, you and the individual regulators, Who's got ultimate responsibility for patient safety?
Everybody who has anything to do with touching a patient. So I would say the primary responsibility is for the clinician who is sitting opposite and recommending and indeed treating the patient. I think ultimately that is where the primary responsibility must lie. Certainly what I felt when I was practicing clinically. And I think the regulatory authorities above that are ways of trying to assure that those individuals and the facilities in which they operate are providing a safe environment and then safe treatment for patients. And that, so it's more than just about the individual, it's about the surrounding buildings, it's about the support staff, it's about the advice that they are given in order to be able to make a choice about the treatment they may choose to take. So, but ultimately, I think if we take that responsibility away ultimately from the individual, then I think that's an error. And everything else is to try and support and make sure that those individuals are practicing in a safe way, in the safest environment. And that's certainly part of our role, we feel.
Thank you.
Valerie.
Yes, I do. Can I ask you about your relationship with NICE? In fact, when you started, you sort of said you didn't have a particularly formal relationship with them. It was different to NHS Improvement. NICE came to give evidence before us, and the Deputy Chief Executive at that point told us that they run an intervention procedural programme which is about looking at safe and effective procedures to be performed by clinicians. But they have no way of enforcing those. They did apparently, once upon a time, they told us that CHI, so your predecessor, did inspect against those standards, but it hasn't happened since. And they mentioned that they had been in conversation with you about reinforcing that, getting that back as an inspection against the standard, but haven't got anywhere. So how can we move that along? I mean, here they are, they're coming up with their best estimates about what good procedures, safe medicine should look like. And they're putting that guidance out there and no one is inspecting against it.
So I have a regular meeting on the general practice side with NICE, and they met just last week. And we continue to talk about how we can ensure that the NICE quality standards are checked during an inspection. Where we currently ask in general practice, for example, do you we ask the question, do you practice evidence-based medicine? Do you look at NICE guidance? Do you disseminate NICE guidance? We need to see examples of that. Again, it's a bit like the Valpro 8 for safety. We need to just look in detail to show that quality standards are being adhered to. And so we do have a relationship with NICE to try and ensure that happens.
But is it a standard against which you inspect?
Yes.
We know that they are going to produce new guidelines very soon for the treatment of stress urinary incontinence, for example. Now, those people who have been damaged by that will play quite a bit of store by that guidance being enforced. Who does that? Who is responsible for making sure that happens? And if it's not a standard against which you inspect, who do they look to for that?
It would certainly form part of our effective key question. So
it will. So these new guidelines, as they come out, will routinely become part of the inspections of pro forma.
So this is work in progress, and as I say, we've been meeting with NICE for quite a long time to try and embed this. And because guidance changes so frequently, well, this is their argument, because guidance does change, they are not desperately keen to have particular examples put in place all the time. But we do produce what's called sector-specific guidance, which is guidance for our inspectors to ask questions, and we have agreed that any current and NICE guidance is actually included. Any new guidance will be included within that, and they will provide us with a list of questions that they would like us to ask, and we'll put that forward for discussion as our next sector-specific guidance review. So that happens every 6 months, and so this is work in progress, and we would like to see more evidence-based medicine being checked up on our inspections. But again, we don't, for general practice, we don't inspect every general practice, except within 5 years. So we will look when we go in, and we will check what we can find when we inspect. But there are big chunks of general practice that will not be inspected for a few years.
I understand that.
So in hospitals, it's not just the fact that we won't be in every hospital every year, but it's the fact that, as I mentioned, we won't be in every core service and in every hospital. What we're trying to do is move to try and check that. So an organisation, for example, will have an executive who is responsible for ensuring that NICE guidance is relevant NICE guidance is enacted in their organisation, or being taken account of. What we will do in our well-led inspections is to check that process, and as Nigel said, then what we'll try and do is test that against a piece of guidance, for example, recent or other. But it won't be every piece of guidance in every trust every time we visit. We simply can't do that. So what we're saying is actually, if the responsibility ultimately is for the individual who is advising a patient or is treating a patient, then the governance internally in the provider they work in is the bit that we would test, because we're better able to test that governance, that it works through an organisation, than trying to test each of the individual bits of guidance.
That's for sure, but one of the ways you test the governance is by looking at a spot check against the piece of guidance.
Indeed. But so the question of which example or examples that we use is difficult.
How is that determined?
If we're in a core service, it would most likely be one of the bits of guidance that is pertinent to the core service that we are inspecting. It may be that, rather as Nigel said, that with the focus being on valproate in primary care, it may be when this NICE guidance is produced that's the bit that we test.
Okay. Can I just come back on the valproate? Sorry, just one more on the valproate. I'm just conscious that with NHS-I improvement, they have recently issued that alert on sodium valproate, which is requiring a sort of systemic approach to reinforce the advice of MHRA. So is that something that you would be testing, that the systemic approach, the advice that the MHRA have to put out, is being enforced? Is that something that CQC would look at across the board?
Certainly in general practice, we ask whether practices are acting on safety alerts. And we look for examples. We always ask for generic examples, and we usually ask for the last 3 safety alerts to tell us how you're reacting to that. But we now particularly focus on valproate, and we always ask our specialist advisor now to look at records of patients who are on valproate to check that there aren't any patients who are of childbearing age, or if they are.
I was thinking more of a system-wide approach, but actually more about the entities rather than.
I suppose that's. Okay. We can do in general practice.
And I mean, there is a group now called the National Patient Safety Alerting Committee, which Professor Baker, our Chief Inspector of Hospitals, sits on as Vice Chair, and they are working with NHSI colleagues to try and work out the best form of communication and assessing how to do that task.
Someone would like to ask me. While you're thinking, perhaps I could go back to Sarah. Do you want to say something about registries?
Well, it's a general comment. You need information in order to act, and if we're going to improve the safety, we need the information. And so I've experienced in my clinical past of being involved with a registry, so that you register the activity, and then with patient permission you can inquire into the outcome. And I just wondered if you have any thoughts about that, because certainly the systems that were involved when I observed the quality based on standardised mortality rates, which are not very satisfactory coming from HES data as they do. We're looking at other alternatives. Now, whether you've got any observations about that?
So my observation in terms of some of the audit, for example, that's being performed, for which some of these new procedures could, I would have thought, become part of an audit. The collection of that data is something that I think that if it's a national audit, people should be contributing all their data to. What we do find is that is not always the case, and certainly it's one of the messages when I'm talking to audiences. I flag the national audits and say that, for providers, if you are providing services for which there is a national audit, our expectation is that those colleagues are contributing their data to those audits. I accept that's slightly different to a registry, but for me the principle is the same, and certainly if it was a a new procedure, one of the things that we would expect, and there is a process for this in providers, as you know, where there is supposed to be a process by which individuals will sign up to that they're wanting to introduce a new procedure, and they will enter their cases case by case. My sense is that either we've got two vehicles potentially currently. One is the national audits, and where, for example, new guidance comes out, as we've said, that I would have thought could be built into their audit process, or as I say, the other area that's of real interest to me, because they've got such richness of data and seem to have such buy-in, is the getting it right first time group.
Yes, thank you. Can I ask another question now? How do you encourage an open culture, both for patients and for staff? The chief executive of the Health Watch 2 or 3 years ago, talking to the Public Accounts Select Committee, mentioned the fear that patients feel if they complain about their doctor that in some way that might affect their continuing access to treatment, and I've also heard it in relation to hospitals. So how can you encourage patients to feel able to comfortably come to you, and how do you protect them if they do? And the same thing applies to whistleblowers.
So in terms of, so we've just started a campaign which is encouraging people to tell us about their care, and we are genuinely interested in people telling us about their care. And one of the things that we say when people contact us is that we can't take up an individual complaint or follow an individual incident, but the information that people are kind enough to share with us, be it good or of poor experience, does form, as Nigel has said, some of the information that we then use to plan our regulatory activity. More generally, in terms of the organisations themselves, we do see that the leadership from boards right the way through organisations is the thing that sets the values and the behaviours and the expectation that that takes that fear away. And
so very specifically, because we're run out of time, but if I was very worried about my care in a hospital, and I contacted the care contact and say, look, this has happened to me, and I really don't know quite what to do, what would you do?
So one of the things, so we would respond, thanking the person for sharing that information with us, and we do genuinely use that information. So the contact is something that that person can be assured that we will use that information. But what we have to tell the individual is that we can't take up the complaint on their on an individual behalf. And what we do is we advise them about the steps that they can take within an organisation, using the complaints process, the PALS process within an organisation, and that if they don't feel either able to or that's given them the response that they need. We also share with them the details of the Parliamentary Health Service Ombudsman, where individuals can take their case further.
And if I, as a young doctor, similarly contacted you, so I'm really worried about what's going on, what would you do then?
So one of the things that we check, and one of the interviews that we do on our well-led inspections is with the Freedom to Speak Up Guardians in all of the trusts. So one of the first things I'd be, we obviously respond to the young colleague. One of the things would be to say, look, have they felt able to discuss that with their Freedom to Speak Up Guardian? And we've seen and met with a number of both junior and senior colleagues on our inspections who have felt able to do that and have felt able to speak to us on inspection as well. And so we feel that's a really powerful mechanism within an organisation. And clearly, if that they didn't feel able to, then we would, obviously depending on what the concern is, we would note the concern. But again, the same caveat applies that we can't take up an individual case. And certainly, we do get contact from doctors, for example, who are in a process of one sort or another in an organisation, and we can't. We can't sort of take up that individual case, but we hear and we listen to, and we will use the information that's shared with us.
And the same applies in general practice. We have, but the access to a Freedom to Speak Up Guardian is more complex in general practice because of the small organisations. And so I was talking to the National Guardian Henrietta Hughes a couple of weeks ago, and we were talking about how we can embed that at somewhere distant from the practice. So Henrietta's starting to look at general practice from April, and likely to be at network level or at CCG level, but it is really important that everybody working in general practice has access to a freedom to speak out guardian, the same as in trusts.
I'm very interested in that conversation. What I need convincing is really that you ensure that you get as much information of the users of the service as you possibly can. And one of the things I was just wondering about, when you are going to do an inspection, do you notify patient bodies? How do you get them actually involved? And taking up Cyril's point, I can understand that some are very reluctant to actually be open and honest because, as Cyril was saying, it's about their future care. Convince me that you are really, A, ensuring that you get the patient voice, and secondly, that you act on it.
So getting the patient voice, when we announce an inspection, we don't always announce an inspection, and this is one of the debates that we're having internally in the CQC. So if we're going to inspect in a provider more than 4 of their core services on an inspection, then we will announce that inspection. And for those occasions, the providers, there'll be notices up inviting people to submit comments or to us. For the unannounced visits, it's slightly more difficult. One of the, as I said, in terms of the response to the national patient surveys, one of the things that every time I get an opportunity to speak, I'm saying that actually we don't want to just hear of patients' experiences, we want to involve them as partners in their care, very much in terms of the sort of approach we take in maternity. And I'm encouraging providers to reach out and engage with their patient representative groups and any of the groups they can, not just to find their experience, but to help plan future service developments. And we know that there are going to be service developments in almost every area of practice over the next number of years, and if those happen without the voice of patients being involved in that planning process, I don't think they'll be successful, and certainly that's one of the things that we are trying to promote. We
do you keep trends? Do you on complaints and things like that?
We
so
do.
You know how you're doing.
We do. Our National Customer Contact Centre keep all of that information, as I say, share it with providers with the relationship owners for providers, and we genuinely use that in terms of how we respond in a regulatory way. So yeah.
Sonia, did you? She's all right. Okay. So I'm just going to ask my colleagues if you have any further questions.
No.
All right. Well, thank you. Any questions you'd like to ask us?
Thank you.
When is the report going to be published? It's often a question that we get asked, and I'm afraid we can't answer that. But thank you so much for coming. We've learned a lot, and it's been really, really helpful. And if we've got further questions, perhaps we can write to you, because I would actually like to know a bit more about your inspectors and how you choose those and all the rest of it. But I think perhaps we ought to move on, because we've got another session coming.
And you're going to let us know your forward plan.
Yes.
Yeah.
The other thing about, we of course have experts by experience who help us by being members of our inspection teams, and we hope that signals, because they are genuinely members of our teams, that the importance that we place upon patients, the public.
Right. Thank you so much. Thank you.
Thank you.